Thanks to the Chairman for my invitation to European Bifurcation Club 2021 and to Boston Scientific for the invitation to participate in this symposium on optimal left main PCI with specific reference to a practical approach to IVUS-guided left main bifurcation PCI. So the advantages in my mind of IVUS guidance are to assess lesion morphology, particularly looking at branch involvement and calcific burden, potentially guiding modification strategy. Then to consider stent selection, sizing, and the length according to healthy landing zones, and ultimately then to achieve stent optimization. I'd like to share a case to highlight these elements. So this is a complex case in her 70s, presenting to a peripheral hospital with non-ST elevation myocardial infarction and found to have severe aortic stenosis with preserved ventricular function, but critical ostial left main stem disease. She was transferred to us and actually underwent BAV prior to the treatment of her ostial left main in anticipation of TAVR. So this is her left coronary disease at the time of intervention, and it shows an exquisitely tight ostium to her left main associated with very high burden calcification in the aortic root. So a guide catheter is carefully introduced with flotation of a wire, you see firstly into the circumflex and then ultimately down the LAD. Predilatation is undertaken just to stabilize the catheter, and then IVUS is undertaken from LAD back into left main, and I'll just bring you back through the IVUS here where we see a quadrant of calcification from 2 through till 4 o'clock. So we come through the proximal LAD, and here we see the circumflex wire coming up at 7 o'clock. And actually then a higher burden, as we'd expect, of calcification within the body of the left main stem, not quite circumferential. And then we come back into the ostium where we saw that exquisitely tight disease, and we already see some disruption by the initial ballooning. Again, non-circumferential, almost completely circumferential calcium at this point, and then really quite gnarly kind of nodular calcium at the level of the ostium. To the left main stem, and a large ostial left main into aorta. So my interpretation of this actually with the protrusive and high burden nature of the calcium is that actually rotational atherectomy is going to be necessary to try and achieve an effective expansion of a stenting device. And actually we see here that protrusive nature, and importantly also by IVUS can confirm the position of the interventional guide wire, which here is in contact with the roof of the left main where the burden of calcium might be. And so one would hope that with multiple Rota runs that we can effectively debulk the lesion. In fact, here we see angiographically a slight improvement following that maneuver. And then again, with a repeat IVUS, we can confirm that we have effectively modified. And again, we see here the circumflex, and importantly, relative sparing of the circumflex ostium in terms of disease, so supporting the potential for a provisional approach. And here we see modification, in fact, with the wire now placed within a cavity generated by the burr passage. And we can see the before and after comparison demonstrating really quite effective modification prior to stent implantation. So a stent is selected based upon the IVUS measurements, and we have a 3.5 by 16 millimeter stent. Sadly, this is prior to the introduction of Megatron, but actually the nature of Megatron would have been ideal here in terms of the ostial placement, need for overexpansion, and potential for recoil long term. Place a 4 millimeter, initially 4 millimeter pot distally, and extend that back to the ostium. And then importantly, take an angiogram which looks effective, but actually the IVUS subsequently shows still some underexpansion in the body of the left main. So here we see the stent edge is free of any dissection. We see the circumflex which has been recrossed, but actually still some underexpansion and eccentricity to the result, which angiographically looks acceptable. Again, just confirming the importance of this IVUS-guided approach. So further optimization with a 4.5 millimeter balloon is undertaken, and importantly, a final IVUS run is taken to confirm adequate expansion, and then we see a much more favorable expansion, achieving an MSA above 10 millimeters squared, ultimately achieving a good result. Now, in hindsight, actually, it would have been useful for this patient to have undergone CT prior to that procedure, but actually they went forward and had a pre-TAVI CT following stenting, And we see what the IVUS has determined for us, this very high burden of calcification at the aortic root. And I think this really, again, confirms that the strategy as adopted by IVUS for use of rotational atherectomy was entirely appropriate. This lady actually returned only earlier this year with some atypical chest pain, and due to the high-risk nature of her previous intervention, underwent angiography, which gratifyingly shows an excellent ongoing result 2 years later. So I hope that in that short case, I have confirmed the advantages of IVUS guidance for left main PCI through assessing lesion morphology, the importance of recognition of calcification and subsequent modification, the consideration of stent sizing, and ultimately the importance of stent optimization to ensure a long-term excellent result for our patients. I thank you for your attention.